conflict of interest. 2-year-old female child, previously well, presented to us with persistent fever with rigors for 3 weeks. There were no other presenting symptoms. There was no contact with TB. On examination, she was febrile with pallor, BCG scar was absent, and there was no failure to thrive. Liver and spleen were palpable. Rest of the system examination was completely normal. Our differentials were as depicted in this slide, with infection being more likely in our part of the world, though inflammatory and infiltrative conditions were also considered in this child. Initial investigations revealed a hemoglobin of 7.5, a blood film showing a microcytic hypochromic picture with no abnormal cells. CRP was increased at 130. Investigations to rule out infections, which we had listed earlier, including blood and urine culture, was negative. Chest X-ray was normal. MAN2 test was non-reactive. The smear and cartridge-based PCR test from gastric aspirate was for TB was negative. Ultrasound abdomen revealed enlarged liver and spleen. Small hypoechoic lesions suggestive of abscesses were noted in the spleen as depicted by the arrow in the slide. IV coamoxiclav was commenced, but in the first week since admission, fever was persistent, as you can see on the fever chart. Liver size increased by 2 centimeters, and there was a rise in CRP. Subsequent tests in the second week showed an increase in CRP, with a repeat blood culture showing no growth. Echocardiography was normal. The bone marrow aspirate cytology showed no abnormal cells. Bone marrow culture was no growth. Since the child remained unwell with continued pyrexia, ultrasound abdomen was repeated, which revealed multiple small abscesses, this time both in the liver and spleen. Hence, the antibiotic was changed to meropenem, and after discussing with our radiologist, an ultrasound-guided FNAC was done from the spleen, which revealed a non-specific necrotizing lesion. Culture from the same splenic aspirate was no growth. In the third week since admission, she continued to remain pyrexia. She appeared more pale as the HB dropped to 4, requiring oxygen support and blood transfusion. Subsequent CT scan of the abdomen showed findings which were consistent with earlier ultrasound findings, with no other intra-abdominal pathology noted. Unfortunately, we could not retrieve the images for this presentation. We were no further forward. Child continued to remain sick, and there were anxious parents too. So we went back to the blackboard, our entire clinical team, including radiologists, microbiologists, and the histopathologists, for a comprehensive clinical review. Fortunately, our histopathologists got back to us to reveal that on FNAC review, a caseating granuloma with epithelioid cells, as depicted in this slide, was seen, which was consistent with TB. We commenced this child on anti-TB drugs, and clinical improvement was obvious in a week's time. On follow-up, our child remained well with resolution of lesions. She went on to complete 6 months of anti-tubercular treatment. She is currently well and is in year 1 at school. So to summarize, we had a 2-year-old with persistent fever with microabscesses in the liver and spleen, FNAC from splenic aspirate suggestive of TB, good response to anti-TB medication, resulting in the final diagnosis of abdominal micronodular hepatosplenic TB, which is rare in a 2-year-old. We wish to highlight the clinical dilemmas that we encountered in the management of this child, which could be discussed by experts in this forum.
Thank you very much for this presentation, and I'm not, we have to watch the chat, but there are no questions yet. So you have presented a young child with abdominal tuberculosis, and if I try to remember the most important things, this child was not BCG vaccinated, or at least did not have a BCG scar. She was in a high-risk age group. You didn't have a contact that couldn't identify the source of infection. Are you there, Jadeth? Yes.
I am here.
You didn't identify a source of the infection? No one else in the household was diagnosed?
No, there was no history of contact with TB in the family.
Yeah, and you had a negative skin test.
Negative, that's correct.
Yeah, this can happen in the beginning of disseminated disease. Did you repeat the skin test later during the course?
No, because she came to us she was already 2 weeks into the illness. The fevers were spiking. So we tried to do gastric aspirate, we did chest x-ray, and we aimed for microbiological diagnosis as much as possible. Because in the initial situation, we were in a we were managing a pyrexia of unknown origin. In our part of the world, we have got a big list of infective conditions. So we had to rule those out first to begin with. So then for TB, we tried to do gastric aspirate, MAN2 test, chest x-ray. These were the things, and the gastric aspirate we also sent for gene expert.
And
so these were the tests that we did in the initial first week to rule out TB.
And all came back negative?
All were negative.
Okay. So what is your explanation? Where is this infection coming from? You didn't find immunodeficiency in this child, at least you report.
The baseline immunodeficiency in the second week, we sent the workup for baseline serum immunoglobulins, lymphocyte subsets were sent. They all came back as normal. So we were in a quandary as to what we were dealing with. This was a real difficult situation because we had a child at the end of 3 weeks constantly having high fevers, very stressed family, and a team of doctors who didn't know what we were treating. And then once we had a combined team meeting, then everybody said, the radiologist, we discussed with the radiologist, and he offered to do a ultrasound guided aspiration of the splenic abscess. And initially they told us it was non-specific, the changes were non-specific. So initially we were in the dark. So then we subsequently, after a few days, we asked them, can you please review with the entire team, including the head of the department? So then they had 4 smears with them. And in the last smear, the photographs that I showed you, they found that granuloma. And so which gave us some inclination that oh, hang on, could this be TB? We started the treatment as an empirical at that point in time with some indication that this could be granuloma because of TB. Because in our part of the world, there is another infective condition called melioidosis, which is caused by Burkholderia pseudomallei, which can also cause granulomas. So, which we have to treat with ceftazidime. But considering TB being more common, so we decided as a team to start the child on anti-tuberculosis treatment. And lo and behold, within a week, we got a response. So looking at the response, we presumed that this was because of TB. And on follow-up at 2 months, all the lesions, everything was completely normal. She's doing extremely well now. She's in year 1.
I've got a question regarding immunity workup, because you said you look at lymphocyte count and white blood cell count. Did you look for CGD, chronic granulomatous disease?
No, specifically NBT we didn't do for this child.
Because they are at higher risk to get mycobacterial infection as well as fungal infections.
Okay.
So for a diffuse form like that.
No, we didn't do tests for CGD specifically.
Okay.
There are some more questions here from the audience. Did you culture your splenic aspirate? And what was culture?
Aspirate, the volume was very less. So we did a smear and we sent for bacterial culture. We didn't have enough sample for TB culture.
Oh, okay. So there was no other TB culture from the abdominal sample?
Unfortunately, we couldn't get enough samples. So we did a smear for AFB. We did a smear for gram stain and for histopathology.
The abdominal tuberculosis is a very rare manifestation of tuberculosis, to my knowledge.
Yes, it is.
So we've just to say we've just looked at the last 1,000 children with confirmed TB in the hospital I work in Cape Town, and we found that 100 had abdominal TB. So about 10% of confirmed TB have some abdominal involvement. So I think that there is this narrative that it's very uncommon, but I think if we look, we actually see it's quite common to get abdominal involvement in TB, and these splenic microabscesses are actually quite commonly seen. So I think if we see splenic microabscesses, we should be the radar should be being raised that potentially this could be TB. Can I ask one question as well? Is if you have these microabscesses in your liver and spleen, they can come from local spread, but they're most likely to be hematogenous spread. And I was concerned that your child was described as irritable at one stage. And if you have a child who's had hematogenous dissemination of bacilli, an irritable child, was this child received a lumbar puncture or looked for central nervous system TB?
No, we didn't do a lumbar puncture, nor did we do CNS imaging for this child.
I just think it's something to think about. I mean, I have to say, I think your management of this child was very good. I think you did all the right things. You investigated extensively for TB and other diseases, and you didn't leap in with treatment. But at some point, you do need to start empiric treatment. I mean, it's totally appropriate if you have a very sick child, and this child sounded very sick, that you need to start treatment for multiple pathogens if you're struggling to find a diagnosis. And you did that, and you've had a good resolution.
We learned hugely from this child. So that's why we wanted to share our experience. The splenic abscess was something new to us. Aspirating splenic abscess was something new to us. So we learned from this child all along the way.
And James, do you think that the infection is most likely via aerosol, or is it ingestion of bacteria?
I don't know what the local prevalence of bovis and pasteurized milk drinking and things in, but I think that in many countries where milk is better looked after, it's very uncommon to get bovis infections now from oral ingestion. So what happens is you get an aerosolized infection. Often it gets into the lung, and either you get disseminated spread through the body, or you swallow your sputum and that goes into the gut. So the original mode is inhalation, but then it gets into the gut through the swallowing of the sputum. That's one of the mechanisms. Can I ask one other final question, if I may, if we don't have any other questions? Did you get any ascites? Was there any ascites on ultrasound scan? Because it can be quite useful.
There was no ascites in this child.
Okay.
This was isolated hepatosplenic involvement.
With the abscess. It's just, if you do have some ascites, sometimes if you can look at the LDH and ADA levels in those, that can be useful if they're very elevated.
So thank you very much for this interesting case presentation. We have got quite enthusiastic comments here in the chat, and I think, yeah, we are moving on now to the next presentation from Anja Meyer from Riga.
So we actually have Liga Berker that will be presenting on behalf of this group, and she's here now.
Oh, okay.
I am Meyer and I'm working in Children's Clinical University Hospital in Riga, Latvia. And today I would like to present you a clinical case with infant with large opacity in the lungs. And this clinical case I have done together with my colleagues in the department. So here's the slide that I have no real conflict of interest that relate to this presentation, and here's also the approval of it. So I will go further for the clinical case. I would like to present you the patient, 11 months old boy, who is hospitalized in our hospital from the regional hospital. So if we talk about this exact episode, the patient started with high-grade fever and a cough, and in the regional hospital, the right side pneumonia was diagnosed in the X-ray. According to the local guidelines, the patient received the therapy with ceftriaxone for 6 days and afterwards with clarithromycin for also 6 days. He improved clinical, but no improvement in the X-ray was seen. So that was the reason the patient was transferred to our hospital. For the patient, there was no chronic disease, no allergies to the medications, and actually this was the first time the patient was ill. He was vaccinated according to national immunization schedule, and the only thing I actually has to mention, the mother was smoking, and she was also smoking during the pregnancy. So the objective findings, if we talk about them, actually when he was transferred to our hospital, there was no specific objective findings. Actually, everything was in the normal range. His skin was clean, visible mucosa was moist, there was no peripheral lymph nodes palpable, heartbeat was totally rhythmic, and breathing through the nose was free. And actually, we couldn't also hear any specific or pathological sounds in the lungs. Abdomen was soft and it was also painless. So as I said already previously, this patient was diagnosed with the right side pneumonia in the X-ray, and he was transferred only to our hospital because there was no improvement in this X-ray pictures. So I will show you those X-rays. Here you can see the first X-ray done in the 26th of February in 2019. So here's this first X-ray where you can see right side pneumonia, and after the treatment there was done the second X-ray where again you can see this right side opacity, and that was the reason he was transferred to our hospital. So maybe you have already some differential diagnosis, you can think some seconds about it, so maybe there's something coming up in your mind. Of course, as our radiologists and pulmonologists saw those X-ray pictures, the next step we went for the CT lungs. Here you can see 3 of pictures from the CT, and our radiologists wrote that actually their main differential diagnosis or working diagnosis was some malignancy or neoplasma in this patient. So as far there was thought about the malignancy, the next steps, of course, the patient also had the full blood count done, C-reactive protein, kidney and liver function, everything, all those lab tests was totally in the normal values. So the patient was also done the trophon biopsy and also bone marrow biopsy and examination. Also in those things, everything was totally fine. So the next step was actually going for the biopsy of the lungs to find out what actually this process or this opacity was in the lungs. So the patient had this biopsy done, and here I will show you the results of the lung biopsy. So here you can see that there was multiple granulomas of different size, with also the specific caseosis necrosis in the center. Around this granulomas were epithelioid cells, histiocytes, lymphocytes, as well as many giant Langhans cells. So of course also this quantiferon TB gold test was done, which was positive. And also we done this bronchoalveolar lavage. Also we were examining the fluid from the stomach. There we didn't find any DNA from the Mycobacterium tuberculosis. So this patient diagnosis is lung tuberculosis. He received at the very beginning combined therapy with 4 anti-TB medications, and later he received treatment with the 2 medications, and also whole family received the medication treatment. And we also found out that actually the mother didn't know that her brother had active tuberculosis, and of course this family was in contact with this mother's brother. And conclusions, and also the main takeaway message, is that we always have to think about tuberculosis as a diagnosis in the case when there is this upper part lung involvement in the patient. Thank you very much for your attention.
Well, thank you very much for this presentation. Dr. Liga Berke, you are representing your group. Anything you want to add to this presentation?
During this therapy, the child at the beginning he was like 11 kilos, and after these 9 months he was gained 6 kilos. So it was really increased in his weight. And about the therapy, maybe he received in the first episode when he was hospitalized. I just wanted to say that ceftriaxone is not the usual case when we give, but we have some argues with our district hospitals. How do we treat children? So just a comment about that.
Okay, and the anti-tuberculosis treatment was well tolerated in this child?
Yes, yes, it was surprisingly, but sometimes it goes very badly. But this child, even at 11 months of age, he was tolerating very, very well.
Mm-hmm. And how do you have a protocol how to check for side effects of the?
Yes, we have Latvian guidelines adapted from World Health Organization, and yes, we go through those steps, what's needed.
And what is your experience with the formulations of these treatments? It's sometimes difficult to obtain liquids that you can easily give to an infant.
Yes, but as you know, Baltic. I come from Latvia, which is near Russia, so we are in a country with the high increase this tuberculosis. So we have very good doctors. Already very for a long time working with the children with the tuberculosis, so they give us very good advices how to give those medications to the child, how to do in a tricky way.
Mm-hmm. Maybe James, can you add something?
Yeah, no, I think it's a very interesting case, and I think it really highlights the fact that young children, especially infants, often present with TB in quite atypical ways. And I think that's just a lesson for everyone listening, is that when you have a younger child, they don't read the textbook, they don't have the classic cough and weight loss, and this was quite an acute history, and it hadn't sort of slightly atypical. I think that's how we just need to be aware of that in especially infants. But did you, just two questions, did you ever confirm the diagnosis from the BAL sample or anything else? Did you ever get a confirmed nothing? And did you get any results from the uncle, the full drug susceptibility test pattern? Was it drug susceptible disease that the uncle had?
Yes, it was, but there was nothing from the culture, just
Okay.
this histological diagnosis.
And did the chest X-ray? Have you done a repeat X-ray? Is this got better? This feature, is it back to normal, or is there something persisting still?
Well, there was a story that after 2 months, it's in the protocol that he had to repeat the X-ray after those 4 medications he received, and it went worse. So he was hospitalized back in our hospital, and we did endoscopy, and it was like the right side bronchi was obturated by this caseosi mass. So it wasn't going so good. So he also received the prednisolone to decrease this scarring of the lung, almost months, and then smoothly went better. This large opacity went smaller.
No, I think that also highlights that these young children, I mean, you can get paradoxical enlargement of the lymph nodes even on effective treatment, which can compress the airways and cause this kind of phenomena. So yeah, they're very vulnerable, these little children.
Yes, and he had no clinic at all, even if this X-ray went worse.
Interesting.
So that's the main home message from this case.
Mm-hmm. But there are some more questions. You have a BCG policy in your country. Was this child BCG vaccinated?
Yes, he was. We have everyone has.
Mm-hmm. And did you do gene expert test on the biopsy?
I cannot answer this question. I followed the discharge papers, but I couldn't find. It's not quite my patient, but I couldn't find this, so I can't answer.
There is a comment from India. For mediastinal lymphadenopathy, we usually do EBUS to confirm nodes as a routine in India. We see 2 diagnoses together, tuberculosis and sarcoidosis, malignancy and tuberculosis, and sarcoidosis and tuberculosis. Did you consider this as a potential combination of?
Not really, because sarcoidosis goes in older children, but and we do not EBUS in children.
Mm-hmm. And then there is another comment that every attempt should be made to get a diagnosis before a treatment is started. I think it relates to this. Yeah, you've tried to do that. Mm-hmm.
Yes, we did everything, and well, the diagnosis was pretty fast done, set because of this histological and also quantiferon test.
Mm-hmm. When did you start the prednisolone? Did you give it as soon as you saw the bronchial narrowing during the endoscopy, or when did you start it?
Yes, it was right when he received 2 months those 4 medications, and we started then 1 milligram per kilogram, and then decreasing the dosage every week.
How often do you see bronchoesophageal fistula as a complication of tuberculosis, local tuberculosis disease? James, is that the question for you?
I mean, not very common. We have seen it, but it's not something we see a lot of, no.
And if this child was BCG vaccinated, do you consider this a failure of BCG vaccination in your child?
No. It just protects him from more severe disease.
Mm-hmm. Yeah, disseminated disease meningitis, like the presentation we just heard from India.
Yeah, it could
Yeah,
yeah.
But we don't consider, a child who has pneumococcal disease and they've had a pneumococcal vaccine, that's a vaccine failure. We don't really think of it in the same way for TB because the vaccine we know is not anywhere near 100% effective. But most children in poor countries have had BCG who get TB, so it's not really considered. I mean, it is a failure of the vaccine, but it's not considered a vaccine failure.
Mm-hmm. There's again the question about the IGRA test for this case. You did it was negative, right?
No, it was positive. I think that was what really swung you, isn't it? With the granulomatous and the IGRA. And I think that the question is does the IGRA confirm the diagnosis? No, it doesn't. But I think it is in a child this young, if they've got a positive IGRA and you've got this kind of clinical presentation, it definitely moves your kind of confidence in the diagnosis, but it's not a confirmed diagnosis. Really, the only way to confirm TB is through microbiology. So the IGRA, the X-rays, the history are not confirmatory. So I don't know if that was part of the question in the chat.
And what is the false positive rate of an IGRA? Is there a false positive rate?
In children with TB? Yeah, so in large cohorts, only about 80% of children with confirmed TB have positive TSTs and IGRA. So about 20% will have negative results, but it gets worse for younger children. So a child who's this young, that rate is probably higher. I don't think we've got age stratified data, but probably only 60 or 70% of children with TB as 11-month would have a positive IGRA. So we definitely can't consider if it's negative that rules anything out.
So it has relatively low sensitivity. The last question I can see here, is IGRA reliable in infants? No, it is not as sensitive as in older subjects. So thank you very much for this interesting case and very good discussion. And we move on to the next case now, which is Amy.
So the third is Linda Life, and she's in the room. Yeah.
Hello, my name is Linda Life. I'm a resident in Paeditrics in Riga Student University, and me with my colleagues Liga Bertinieva from Children's Clinical University Hospital of Latvia will present you a clinical case about child with pleurisy. Know real or perceived conflicts of interest that relate to this presentation. The clinical case is about a 7-year-old boy who has transferred from regional hospital with subfebrile temperature at daytime and febrile at night, no other symptoms, CRP 50 milligrams per deciliter, and leukopenia, with no improvement in dynamics by using antibiotics. In X-ray, thorax and CT scan of thorax, the left side pleuropneumonia is seen with hydrothorax. Here are the CT scans. What was known about this guy, that he born premature. At the age of 2, he had asthma symptoms and used therapy till age of 5. He has epilepsy, sees neurologist and uses levetiracetam. All the vaccination is done. All the family members are healthy. Grandmother and grandfather has cough, and he spent 3 weeks in summer with them, but otherwise are healthy. When he comes, only we see he's changed the temperature, which is 37.2 degrees per Celsius, and in auscultation, impaired breathing left side of lung. All the blood tests are normal, except CRP is 22.2 milligram per liter, and lactate dehydrogenase is 500 units per liter. In ultrasound, hydrothorax in both sides is seen in left side till 3.6 centimeters, and in X-ray, massive hydrothorax as you see in the picture. What would be your possible diagnosis? For us, it was tuberculosis, and maybe malignant process, or maybe resistant microorganism made MPMA. So we did the puncture, did the drainage, took the sample for later testing, tuberculosis included. And in therapy, we started cefuroxime, clindamycin inhalations, and physiotherapy. But temperature stayed subfebrile, boy felt bad, there was no appetite, and still no other symptoms. When the tests results started to come to us, the mycoplasma pneumonia was negative. Still, there was fluid in pleural cavity, which was seen in control X-ray and ultrasound. But then we got the answer for quantiferon test, which was positive. So we started therapy with isoniazid, rifampicin, etambutol, pyrazinamide, and prednisolone. As you see, all the tests for tuberculosis came back, but all of them was negative except quantiferon test. In dynamics, we got other analyses too. Legionellosis was negative, HIV was negative. But using this therapy, boy started to feel better. He started to eat. There was no temperature rises. Pleural fluid was gone. We took out the drains. CRP lowered. After some time, we made the control CT scan, which was good. So tuberculosis is an active disease worldwide. In 2018, 1.1 million children fell ill with tuberculosis globally, but not always it is well recognized by health providers and not easily diagnosed. In 2019 in Latvia, there was 403 new tuberculosis cases, but only 346 of them was bacteriologically approved. Case report shows struggling with hard healing pleural pneumonia with hydrothorax, which leads to differential diagnosis, malignant process and infectious process, in this case tuberculosis. Even though microorganism was found, the improvement after anti-tuberculosis therapy is seen. So the positive quantiferon test and positive outcome by using anti-tuberculosis drugs approves tuberculosis etiology of pleurisy. Thanks for your attention.
Hi, my name is Tina Sherman. I work at the Children's Hospital.
Linda, there you are. Yes, thank you very much for a nice presentation. Another aspect of tuberculosis disease.
So one question that's coming up in the chat a bit is measuring other chemicals in the pleural fluid. One of them is ADA, but also LDH, and interferon gamma release assays can be done on the pleural fluid. I don't know if you did any of those tests on the pleural fluid. We can't hear you, I don't think, Linda.
Can you start your microphone, please, Linda? Amy, can you?
She's not muted, so.
She's not muted, so she may have to answer in the chat if we can't hear her.
Okay.
Now you can hear me?
Yes.
Can you hear me? Yeah. ADA, we are now we don't do in our hospital. It's not possible test in our hospital, and we usually don't do it. Yeah, and yeah, and foreign kind of tuberculosis. So, and how patient improved after therapy, it showed that we don't need to search for something more.
So in terms of confirmation of diagnosis, you have one single positive IGRA. And do you have an index case?
Index case?
An index case. Someone in the family that was positive,
no.
But the grandpa and the grandma had cough.
Everyone was checked. Everyone was checked, and the grandma and grandpa was the first which were checked, but none of the family members were positive. So we don't know where this child got the tuberculosis.
I mean, I would agree with you that with this clinical presentation and with a positive IGRA and a good response to treatment, it's very likely this is TB, but I don't think we can say it's confirmed TB. But I think that you were right in starting treatment when you did.
In the pleural fluid, what was the cellularity of the pleural fluid? It was mainly neutrophils, lymphocytes?
Lymphocytes.
Okay.
And well, I didn't include it in the presentation. Before the therapy was started, we took more samples, and in one sample came back the positive DNA of tuberculosis, but the sample was so small that they couldn't check sensitiveness on rifampicin. So yeah, it was just one small sample that came later on to us, but yeah. That's all we got. Yeah, but we started therapy without this positive DNA of tuberculosis.
But that would be a confirmation of the diagnosis, James. Don't you agree?
Yeah, no, absolutely. Can I ask about the prednisolone? To my understanding, I don't think there's good evidence one way or another, but I think really the guidelines suggest you use steroids in meningitis and pericarditis and not much else. So I mean, it's entirely possible steroids help in other conditions, but I don't think there's a lot of evidence. Can you explain why you use steroids?
Yeah, because there was a massive hydrothorax, and we read some studies that it can help to resorb it faster and kind of slower down the septation in the pleural space. So it was used because of that.
Okay.
Yeah.
Can I ask one other question? You wrote in your last slide that there were 403 children with TB in your country, and
no, all cases, I guess. Yeah, but not all of them was the cultures was.
Yeah, this is what I'm getting to. You said that you said that only 346 were confirmed. Now, that would slightly concern me. I would hope that actually, you know, you were confirming the diagnosis in almost all the children, which worries me that there are a lot of children out there who should have been treated for TB, for unconfirmed TB, because we only really confirm the diagnosis in 30–40%, even when we try very hard. So I find it somewhat concerning. I mean, I think if you've confirmed the diagnosis in 346 children, you should be expecting to see 600 or 700 children. So I worry from those statistics that maybe there are some cases being missed. I mean, unless you're absolutely amazing and you're confirming it in 80 or 90% of children, which, I mean, it would be unusual in the rest of the world.
Yeah, it's possible that we don't get all the cases, but.
There is a question about putting in a chest drain if you have a tuberculosis pleural effusion, whether there is a risk to get a fistula, a skin fistula, pleural fistula. What is the experience with that? And pleural effusion with low cellularity, the risk is probably, if it's an empyema, I can imagine, yes. James, what is the experience in a?
Yeah, I just think I mean, I think that it's always something you have to think about, especially, and you don't know necessarily it's going to be an empyema or serous fluid when you put the to drain in. I mean, you might stick a needle in first, but you can't leave a child with half a lung full of fluid. I mean, you just can't. It's not going to heal properly. The drug are not going to penetrate in there, and it's compromising their breathing. So I think if the degree of fluid, you took 600 mils out, you can't leave 600 mils of fluid in someone's thorax. So I agree, it's something you need to think about, but I think that level of fluid has to be removed.
But I mean, the fluid looked very of low echogenicity, so a little organization within the fluid space. So you can always use a very small bore or even a pigtail catheter for drainage, and that will probably decrease any risk of creating a skin fistula, I think. Is there a role for video-assisted thoracic surgery in such a case?
It was no. In this case, there was no video. It was the first etap in our hospital. The surgeons came for help, and the main goal was to get the fluid out so the breathing gets better. Because, as you see, there was a tachypnoea for this child.
I quite agree. The first diagnostic
all fluid was tested.
Diagnostic drain or a diagnostic puncture, and then if this doesn't work, then one can put in a drain, and only if you don't get relief of symptoms, then you have to consider a video-assisted procedure, which is much more invasive.
Yeah, that's why we didn't take a biopsy too, because we tested the fluid first. If it would be needed, then maybe we would do this procedure. But yeah, first we tested the fluid.
Okay, we probably do need to move on. It's just time is marching on, but thank you very much for a very interesting presentation.
So Alice, this is yours, I think.
In Zurich at the pulmonology department, I'd like to present you a 10.5-year-old girl who was referred to me by a GP with suspected asthma. Her symptoms were especially an exercise intolerance and a dry cough that she experienced since 2 to 3 months. She even said that she had sometimes inspiratory sounds at exercise and tachypnea. There was no improvement of the symptoms after 2 puffs of salbutamol. And she even said that she couldn't walk to school anymore, and it didn't really seem odd to the family. They just started driving her to school. She even had to pause while walking the dog. Her lung function showed a significant restrictive pattern with hyperinflation. We first weren't even sure if she didn't participate well, but that was actually the best that she could. On examination, she appeared in good general health. She was normally weight and had a normal height. Her breathing frequency was slightly elevated, heart rate normal, and her oxygen saturation was decreased at rest. She even had some sort of speech dyspnea, which also didn't appear to the family to be different than normally. She had no retractions, no flaring, no clubbing. Her breath sounds were normal, and the rest of the examination was also normal. We decided to send her on to the lung. It wasn't really spectacular, but did show a slight interstitial pattern bilaterally, especially in the upper lobes. So we decided to send her on to CT, and on the CT we saw a significant ground glass pattern bilaterally, pretty homogeneous centrilobular, with some areas of normal lung tissue in the upper and anterior lobes. There was no air trapping on exhalation slides, and there were 3 little nodules in the lower left lung, which you can't see on these slices here. And this gave us the high suspicion for a hypersensitivity pneumonitis, or exogen allergic alveolitis, as it used to be called. So we went to patient history and tried to find the trigger of this disease. And they had moved into a new house a couple of months ago. It was an older house which was newly painted, but there was no mold, no damp environment. They had new beds, no fountains. They did have a jacuzzi outside, but it was new. They had a dog which they've had for years. No birds, no exposure to stables or hay. And we went over and over these potential factors, and it took us literally hours of talk with the family when suddenly the younger sister said, "But Mom, didn't these symptoms all start when we got the new decoration?" So this was a clue, and we asked back on what kind of decorations they had, and they send us this photo of these 3 artificial birds that I had bought for the entree of the new house, and they were made out of real bird feathers. So this was really a clue on a possible trigger. We admitted the girl and started a treatment with methylprednisolone intravenously for 3 days, and she also needed oxygen supplementation through nasal cannula during the first night, and after that the saturation improved. Lung function at the day of discharge, so after 3 days, already had significantly increased, as you can see here, with FVC and FEV1 in the mid-50s, and we decided to continue the steroid treatment with prednisolone orally over 10 days with 2 mg per kilo per day. After discharge, we got back the lab results for specific IgG, and as you can see, it did show elevated levels for pigeon and parrot, and we know there's a high cross-reactivity between birds, so it did prove the diagnosis of a bird-induced hypersensitivity pneumonitis. There was also elevated Aspergillus IgGs, which we didn't really know if it was responsible as well for the disease course, but I will get back to that later. The follow-up after 14 days, so 3 days after steroid cessation, showed much improved symptoms, still some dyspnea at exercise, and the lung function was stable, even improved by another 10%. The DLCO, which we did for the first time at this time, still showed significant decrease of diffusion capacity. We did regular follow-ups, and after 4 months we repeated the immunoglobulins, and we saw that the values for the bird immunoglobulins decreased by half, which showed us to be sufficient that the family had banned all feather-containing material from the house. We also saw that the Aspergillus immunoglobulins had decreased now to normal ranges without any environmental measures have been taken, so probably this was not responsible for the disease cause. The last follow-up we did after 2 years, and the girl didn't have any complaints at all, and her lung function was normal. Thank you very much for your attention.
Okay, thank you. Is the presenter with us?
Yes.
Yeah. Okay, hi. Okay, I've got some questions to start. You did not perform a BL.
I know this question was going to come. No, we did not. We did the CT, and I saw the patient in the outpatient clinic in the late afternoon. And after the X-ray, we performed the CT on the same day, and it was already late. And the radiologists were pretty sure about the diagnosis because of this homogeneous ground glass opacities. And that's why we didn't perform a BL before we started the treatment. And since she improved after the steroid, already after the first night, we didn't add that on the next day either.
Okay. However, I would not recommended it because it could have been an intra-alveolar hemorrhage, which can give the same sort of images with like spots of ground glass opacities everywhere, and it's important to know if it's blood or if it's hypersensitivity pneumonitis. And it can be
Sorry,
also...
what could it have been?
Intra-alveolar hemorrhage.
Okay.
Okay. And also because you can't rule out an infection. So before treating with steroids, I think it should be systematic to perform a BL when you have such diffuse images even if the girl was previously completely healthy with no specific past medical history. I guess the other faculty will agree, and you will get the results of microorganisms culture in 2 days. So I think she would have been able to wait for 2 more days because she was not, she did not have a need for IQ or, you know, so you had some times before treating. For the Aspergillus fumigatus, you said that she had a jacuzzi. Did you perform sample of the jacuzzi just to check that there was no fungal agents or other thing that?
No, we didn't. We asked about plants and composts and everything like that. They didn't have. The only thing was this jacuzzi, and since it was a new one, and they said they had chlorided.
Okay.
We didn't worry about it so much until we got all the results back. We told her, of course, to not bathe outside in those 2 pools. And after we had the positive test for the birds, we assumed that it was from this. And also since the history kind of matched with the onset of the symptoms.
Okay.
But we were definitely happy that the Aspergillus IgGs decreased back to normal without any specific measures. So this sort of remained a question mark at the beginning. But after it normalized in the end, we think it probably wasn't part of the cause. Or what is your opinion?
What I saw in jacuzzi was atypical mycobacteria that led to some reactive pneumonitis. I never saw it with Aspergillus, but as it is a fungal agent that jacuzzi is water, I think you should have some case like that. But usually Aspergillus will give like as bronchopulmonary allergic aspergillosis, so it's not the same pattern. So I agree, it's probably the parrot. Okay, we have some question in the chat. Is the IgG antibody test to bird antigen easily available?
Well, in our country, it's only made in one hospital in Geneva. So we have to send it abroad, and it took quite a while, I think about 2 to 3 weeks until we got the results back.
Okay. In France, there are several centers, but most of the time you have at least one center per country. Do you need to repeat specific IgG upon follow-up, especially in low resources center?
Well,
because you repeat the dosage.
Sorry, we repeated.
You repeated the dosage of the IgG. Do you need it? Do you think it is necessary to do it?
Well, probably if the clinical course is favorable, you probably don't need to. For us, it was because we were not quite sure about the Aspergillus, and that was one of the reasons why we repeated it, because we wanted to see that those values decrease. And I mean, it's sort of a proof that you have banned the antigen correctly from the environment.
Okay.
That there's no ongoing exposure.
If there is a clinical improvement, there is, I think, no need to control. It's not. How was the hypersensitivity pneumonitis confirmed? Sputum's test down, so the answer is no. Is 10 days of steroids enough? Especially because lung function tests remain abnormal for a long time. Usually, I think we treat much bit longer and with tapering very slowly the dosage. But it is usual that the improvement is very fast when you both associate oral steroids and also the eviction of the responsible agent for the pneumonitis.
May I ask how long did this child stay in hospital?
For the 3 days.
Okay.
For the IV methylprednisolone.
Yeah, okay. I mean, the other option would be to just leave her in hospital for a week or so and see how she does when there's no allergen in the environment, and then decide whether you need prednisone or just evacuate her from the allergen.
So then you wouldn't treat with steroids at all, just take it away from the environment.
Very acute presentation. You might just wait and see whether with allergen avoidance she improves clinically and in terms of lung function, and then it may be all right. But if she doesn't improve soon, then I would start steroids. And the course of steroids, of course, depends on allergen identification and avoidance and course of lung function.
I think the avoidance is very important, but she had a quite important restrictive ventilatory defect at the beginning. So I'm not shocked by the fact that you immediately start on steroids for her. But someone says HACT was not suggestive of hypersensitivity pneumonitis. Can we proceed with further investigation? I do not totally agree. For me, it was very subjective of hypersensitivity pneumonitis. It's a typical pattern. But again, it's not sufficient to ascertain the diagnosis. So owing to the fact that you will need some weeks to have the result, to get the results of the IgG, that's why the BAL can be useful, because it will help you to rule out an infection cause, and it will also give you some arguments with the CD8 over CD4 ratio. So I think it's useful. Going down again. I'm trying not to miss a question. Similar CT scan could be seen in asthma. No, I do not agree. Usually in asthma, chest CT scan should be either normal or just showing signs of chronic bronchitis with thick bronchial walls, but not interstitial lung disease. Other faculty can interrupt if they do not agree. Okay. And I think it will be time to end.
Yes, please.
Okay, yeah, okay. So last question, do you check for pulmonary hypertension in case like the one presented? Sometimes pulmonary hypertension gives images such as a ground glass opacity, but the pattern and the localization are not quite similar. The pattern that we saw is very typical of hypersensitivity pneumonitis or bleeding, but not really for pulmonary hypertension. But as she had dyspnea and exhalation, it would not have been a mistake to perform a cardiac ultrasound.
Can I ask you, so the hemorrhage, the alveolar hemorrhage, will be so homogeneous throughout?
It can be if this is an acute and severe episode, but she would have had anemia, I think.
Yeah.
Monica, we can't hear you. Your micro is switched off.
It's just you did lung function test including the diffusion capacity, and that
it was very low. Yes, but we did not get it at the first lung function test. It was only at the second test. So thank you. Thank you, everyone.
Thanks. No, fascinating case. Cheers.